Hi everyone, are you able to hear me? Okay, I'm Dr. Pranitha, consultant neonatologist and pediatrician. Today I'm going to discuss about persistent pulmonary hypertension in neonates. So PPHN is a nightmare, especially for doctors working in NICU. Hi everyone, are you able to hear me? Dr. Pranitha, consultant neonatologist and pediatrician. Today I'm going to discuss about persistent pulmonary hypertension in neonates. So PPHN is a nightmare, especially for doctors working in NICU. So sorry, there were some technical issues. So I'm going to discuss the topic under the following headings: the normal transition, etiology, pathophysiology, diagnosis, and treatment. So this is a normal fetus. A fetus is in a state of physiological pulmonary hypertension. The lungs are filled with fluid. Gas exchange only happens through the placenta. And the pulmonary arterial PaO2s are very low in both the arteries as well as venules. It is only 17 to 19 mm of mercury. The pulmonary vessels are in a state of constriction. So even when though there is hypoxemia, the baby is able to tolerate this and there is no hypoxia, mainly because of three reasons. One, because of high cardiac output. Two, because of high level of hemoglobin content. And three, because of high content of fetal hemoglobin. So post-birth, baby starts crying with the help of the brain and the fluid from the lungs is expelled out. After initiating 4 or 5 breaths, usually pulmonary blood flow increases almost 5 to 10 times the level in the fetus. And with the entry of oxygen into the alveoli, the vessels are dilated, pulmonary vascular resistance falls, and there is increase in alveolar oxygen to 100 to 150 mm of Hg. So there are 5 main things which happen during the fetal to neonatal transition. Fall in PVR, increase in systemic vascular resistance, and closure of 3 communications, the ductus arteriosus, ductus venosus, and foramen ovale. So let's briefly see the fetal cardiovascular physiology. So fetus derives its oxygen from the placenta, and the oxygen content in the placenta is almost 80 mm of mercury. The blood flow from the placenta goes into the umbilical vein, then it goes into the ductus venosus, from where it passes into the right atrium. And since the foramen ovale is open, 90% of the blood is shunted to the left atrium, from where it goes into the left ventricle aorta and is preferentially distributed to the brain and coronaries. Only 10% of blood from the right atrium goes into the right ventricle into the lungs, and other deoxygenated blood from the rest of the body also comes from the lungs into the right atrium, left atrium, left ventricle, and it is again shifted back to the placenta for oxygenation. So coming to the normal and newborn cardiovascular physiology, after birth, the umbilical cord is clamped. So there is removal of low resistance placental channel. There is increase in systemic vascular resistance. Along with it, baby also cries and the fluid from the lungs is expelled. The PVR falls, pulmonary blood flow increases almost 5 to 10 times, and the blood flow from the lungs moves into the left atrium. The left atrial pressure increases, and this causes functional closure of foramen ovale. So now the blood comes, deoxygenated blood comes from the SVC and the IVC into the right atrium. But since the foramen ovale is functionally constricted, now the blood moves into the right ventricle, from where it goes into the pulmonary veins into the lungs for the oxygenation. The oxygenated blood from the lungs comes back into the left atrium. Because of the increase in oxygen content in the blood, PDA also functionally closes. So the blood returning from the pulmonary veins into the left atrium moves into the left ventricle, and then it is distributed to the rest of the body. So this is the normal cardiovascular physiology. So this is again the same thing. So the hemodynamic changes which happen at birth are, after birth, systemic arterial pressure slowly increases and it is maintained over time. The pulmonary artery pressure slowly falls, declining, and it reaches the adult levels over a month. The pulmonary blood flow sharply rises after birth. So in the fetus, placenta is the organ of gas exchange, whereas in the newborn, lung is the organ of gas exchange. In fetus, there is suprasystemic pulmonary vascular pressures, whereas in the newborn, the pulmonary vascular pressures should decline. The pulmonary blood flow is low, less than 10% in a fetus, whereas it increases steadily in a newborn. There is very low level of oxygen consumption in fetus, and it increases in a newborn. The blood flow is from right to left via ductus arteriosus and foramen ovale in the fetus, whereas in the newborn it closes. And the ventricles act parallel, with the left ventricle supplying the head and upper extremities and the rest by the right ventricle, whereas in the newborn, 2 ventricles act in series and have same cardiac output. So this is the normal transition at birth. In case if there is something like asphyxia, hypoxia, acidosis, hypothermia, or any other factor which causes abnormal transition, this leads to PPHN. So PPHN is defined as persistence of fetal pulmonary hypertension leading to shunting of blood, resulting in severe hypoxic cardiorespiratory failure. So the risk factors antenatally for the presence of PPHN are mother with chronic PPRON, oligohydramnios, IUGR baby, post-maturity, diabetes in mother, cardiac lesions in the baby or lung lesions in baby, and usage of NSAIDs or SSRIs in pregnancy. So pulmonary hypertension is basically derived from pulmonary artery pressures. Pulmonary artery pressure is the sum of pulmonary capillary wedge pressure plus pulmonary blood flow into pulmonary vascular resistance. So any factor which is going to affect any of this is going to increase the pulmonary artery pressures. Pulmonary capillary wedge pressure is usually increased in any arteriovenous malformations, which increases the shunting of blood and, like for example, vein of Galen malformation. Pulmonary blood flow usually increases in all the lesions which increase pulmonary blood flow, like all the cardiac lesions which are associated with increased pulmonary blood flow. And PVR basically increases in all lung lesions or hypoxia, acidosis, sepsis, etc. So let's discuss the causes of PPHN. PPHN is broadly divided into primary PPHN or the idiopathic PPHN, where there is no lung issue. The issue is with the pulmonary vessels, and secondary PPHN, where the PPHN is caused because of secondary issues in the lung. They are broadly divided into 4 types: maladaptation, maldevelopment, pulmonary hypoplasia, and intravascular obstruction. So maladaptation is basically because of asphyxia, TTNB, RDS, pneumonia, meconium aspiration, and hypoxia, asphyxia, acidosis, polycythemia, sepsis, all of which cause severe acute pulmonary vasoconstriction after birth. So here the blood vessels are normal in number as well as in the structure, but there is vasoconstriction in the vessels which lead to increased PVR and pulmonary hypertension. The second type is maldevelopment, where there is problem in the development of the vessels. So the blood vessels musculature is increased, and this is basically seen because of alveolar capillary dysplasia or surfactant protein abnormalities, chronic intrauterine hypoxia, PPRON, or antenatal ductal closure. The third type is pulmonary hypoplasia, which is seen in diaphragmatic hernia, chronic oligohydramnios, PPROM, or intrathoracic space occupying lesions, where the lung is occupied by the intestines or any other space occupying lesions. So the number of the pulmonary vessels are reduced, which leads to PPHN. The other cause is intravascular obstruction, either because of hyperviscosity or polycythemia. So one or two may coexist in one particular baby also. So increased PVR leads to maladaptation of pulmonary vasculature, leading to reflex vasoconstriction. This is seen in parenchymal lung disease like asphyxia, MAS, pneumonia, RDS. Or it can be seen with hypoxia, hypercapnia, sepsis, acidosis, hypocalcemia, hypomagnesemia, hypothermia, polycythemia, or any other thing which leads to stress to a baby. And pharmacological drugs like maternal SSRIs. In maldevelopment, there is muscularization of pulmonary acinar arteries leading to remodeling. This is seen in chronic in utero hypoxia like IUGR, post-maturity, maternal paracetamol or NSAIDs therapy. And underdevelopment of pulmonary vasculature is seen in CDH, alveolar capillary dysplasia, surfactant protein deficiencies, or pulmonary hypoplasia associated with chronic PPROM, oligohydramnios, and anhydramnios. There are certain developmental lung disorders which are also associated with PPHN, like trisomy 21, TBX4 mutations, alveolar capillary dysplasia because of FOXF1 mutations, CRH receptor 1 mutations, and congenital surfactant protein deficiencies. So we need to suspect this whenever there is severe PPHN not responding to conventional therapies. Other uncommon causes of PPHN are hepatic AV malformations, cerebral AV malformations, or vein of Galen malformations, pulmonary vein stenosis, which is seen in premature babies with severe BPD, and premature ductus arteriosus closure. So following asphyxia, also PPHN is very common, and there are 5 main factors which predict the severity of PPHN in a case of asphyxia. They are severe asphyxia at birth, anemia with low hemoglobin levels, need for chest compressions or adrenaline, and if there is presence of a lung disease with MAS or pneumonia, or requirement of more than 50% of FiO2 in the immediate postnatal period. So let us see the pathways of PPHN. So there are three main pathways: the cyclic GMP pathway, cyclic AMP pathway, and the ET pathway. So after birth, with the help of increased oxygen levels in the body, along with shear stress, this leads to the conversion of arginine to citrulline, and inhaled nitric oxide synthase, ENOS, is produced. So this produces nitric oxide, which leaves the endothelial cells and moves to the smooth muscle cell. Here, NO acts on guanylate cyclase and converts cyclic GMP to GMP. So GMP decreases calcium level and causes vasodilatation. This conversion of cyclic GMP to GMP is inhibited by enzyme phosphodiesterase 5. So this is where sildenafil acts. So that is how INO and sildenafil are synergistic in action. So coming to the cyclic AMP pathway, cyclooxygenase and PGI synthase enzymes acts on PGI2. So this produces prostacyclins, which attaches to the receptor and acts on adenylate cyclase, which leads to formation of cyclic AMP. Cyclic AMP is then converted to AMP, which again reduces calcium levels and causes vasodilatation. This conversion of cyclic AMP to AMP is inhibited by the enzyme phosphodiesterase 3A, and this enzyme is inhibited by milrinone, and that is how it acts on in PPHN. The third pathway is the ET pathway. Here there are two receptors, ETA and ETB. So ETA causes mainly vasoconstriction by Rho kinase pathway, and ETB causes vasodilatation by acting on endothelial nitric oxide synthase and increasing the nitric oxide levels. So these are the factors affecting the pulmonary vascular tone. Vasodilators are oxygen, alkalosis, nitric oxide, prostacyclins, bradykinin, and adenosine. And vasoconstrictors are hypoxia, acidosis, endothelin 1, PGF2 alpha, leukotrienes, and thromboxane. So let's discuss what happens. So after the increase in pulmonary artery pressures are seen, there is basically effect on the right ventricular function, mainly because of increase in afterload. So there is decline in both systolic as well as diastolic function. Along with this, there is shunting of blood across the PDA and PFO, right to left shunting, which again decreases the pulmonary blood flow. So all this acting conjunction decreasing right ventricular output and right ventricular filling. Because of decrease in pulmonary blood flow, there is hypoxia, acidosis, ventilation of perfusion mismatch. So since both the ventricles act in conjunction, because of right ventricular dilatation, decrease in functioning, and decreased RV output, the effect also falls on left ventricle. The LV preload decreases, leading to LV dysfunction and decreased left ventricular output. Finally, there is systemic hypoperfusion and shock. So a vicious cycle of PPHN, increased pulmonary pressures, right ventricular dysfunction, and shock continues. Coming to the clinical features of PPHN. So we suspect PPHN usually in a term or post-term infant when there is cyanosis, respiratory distress, hypoxia, which is out of proportional to the lung disease. There are labile or fluctuating saturations. So in PPHN, labile saturations are characteristics. So this is not usually seen in cardiac lesions where the saturations are usually persistently low. And on examination, we can appreciate prominent precordial pulse, murmur of tricuspid regurgitation, which can sometimes be present in normal newborns also, and a single loud S2. So when we attach pulse oximeter to the preductal and postductal saturations, there is usually difference of more than 5 to 10% of gradient in preductal and postductal saturations. So coming to the hyperoxia hyperventilation test, this test is now obsolete. It shouldn't be done. We are just discussing it for theoretical purposes. So handbagging is done with the 100% oxygenation, and hyperventilation is also done to decrease the PaCO2 levels. And after 10 minutes of hand ventilation, we are going to measure the PaO2 in the preductal blood vessels. If PaO2 is more than 300, it is usually a normal infant. If PaO2s are between 150 to 300, the cause of the hypoxia might be because of a lung disorder or brain disorder or methemoglobinemia. If the PaO2 is between 100 to 150, we need to suspect PPHN, and it is also seen in cardiac mixing lesions with increased pulmonary blood flow. If PaO2 levels are less than 100, it is usually seen in cardiac conditions with parallel circulation and heart lesions with restricted pulmonary blood flow. Coming to the X-ray, in X-rays we might see usually normal X-rays, the hypoxia might be disproportionate to the level of findings in the X-ray, or we can also appreciate the findings of the lung disorders, like in the first X-ray, we are seeing RDS with whiteout lungs, air bronchograms, retrogranular opacities. The second X-ray is showing fluffy infiltrate suggestive of MAS. The third X-ray is showing pneumonia. In idiopathic or black PPHN, lungs are usually black and appear normal. And we can see the intestines in a case of CDH. So if there might be cardiomegaly also along with right heart enlargement. So echo is the gold standard for the diagnosis of PPHN. It is also most helpful in monitoring the therapy, weaning the therapy also. So this is a normal heart with a parenchymal disease. Here we can see that the left ventricle is O-shaped. It is bulging into the right ventricle. The blood flow across the patent foramen ovale and the PDA is again left to right. So there is no tricuspid regurgitation. If we see such findings in an echo, it is mostly a normal heart with parenchymal disease without pulmonary hypertension. And the main strategy is going to be lung recruitment. Coming to a heart with PPHN, here we can see the blue jet across the right ventricle to the right atrium, the tricuspid regurgitation, and the right ventricle, the interventricular septum is bulging into the left ventricle. So the left ventricle is crescent shaped, and the blood flow across the PFO and the PDA is right to left. So this is a case of PPHN. So let's see how we evaluate PPHN step by step. The first step is going to be ruling out the cyanotic congenital heart disease. So whenever we are treating PPHN or whenever we are trying to start inhaled nitric oxide, the first thing is to rule out duct-dependent lesions. So there are many mimickers of PPHN like the left-sided obstructive lesions like coarctation, interrupted aortic arch, HLHS, or other cyanotic heart lesions like TAPVC, TEGA, pulmonary atresia, Fallop's tetralogy, tricuspid atresia, or severe Epstein anomalies. So always rule this out before starting INO. The second step is estimation of pulmonary artery pressures. So this we are going to evaluate the TR jet. So this is the apical 4-chamber view. The atria are present upper side and the ventricles are present lower side. This is the 2D echo picture. And when we place a continuous, when we place color Doppler across it, we are going to appreciate a blue color jet because of flow of blood from the right ventricle to the right atrium. And we need to place continuous wave Doppler. The angle of insinuation needs to be narrow. And after placing a continuous wave Doppler, we are going to appreciate these kind of waveforms. So we're going to calculate the peak of the jet. And here the peak velocity is 5. So using Bernoulli's principle, we are going to calculate the pressure gradient as 4 into velocity square. So 5 square is 25, 4 into 5 is 100. And we are going to add the right atrial pressure, which is 5. So here the maximum TR jet is 104, which is like very high, suprasystemic PAH. And the blood pressures here are 59/42 and 48. So while tricuspid regurgitation is very, very useful for diagnosing PPHN, it may not be present in all the cases. It is only seen in 60 to 85% of cases of PPHN. So TR jet might be absent, especially if there is right ventricular dysfunction here. The right ventricle is not able to expel the blood into the right atrium, or it can be seen in right-sided obstructive lesions also. The second step, the third step is assessment of shunt across the PDA and foramen ovale. So this we have discussed once previously also. So initially after birth, there is basically increased pulmonary vascular resistance. So the jet is seen below the line. There is right to left shunt across the PDA. As the pulmonary vascular resistance starts dropping down and as the systemic vascular resistance starts rising, it becomes a bidirectional shunt with left to right shunt seen above the line also. So this we are going to assess both in the foramen ovale as well as the PDA. So this is color Doppler in ductal view, where we are seeing the main pulmonary artery dividing into RPA, LPA, and in the presence of duct, we see a third jet. This is the 3-leg stool appearance. And when we place a Doppler across this, we are going to appreciate the jet below the line, which is the right to left shunt. Whereas in the presence of a left to right shunt across the duct, we are going to see an orange colored jet with the jet seen above the line. So based on the echo characteristics, we are able to divide PPHN into 4 types. So we have already discussed the second one and third one. The second one is PPHN and third one is a normal normal heart with pulmonary disease. So in heart with left ventricular dysfunction, because of the LV dysfunction, there is paradoxical flow of right to left shunt across the PDA, but across the foramen ovale, there is left to right shunt. So this is seen usually because of the left ventricular dysfunction, and here the circulation is dependent on the right ventricle. And coming to duct-dependent pulmonary circulation, in the presence of any right ventricular obstructive lesions like tricuspid atresia, pulmonary stenosis, here the pulmonary circulation is dependent on the left to right shunt across the PDA. So in the PDA, we are going to see the left right shunt, whereas across the foramen ovale, we are going to see the right to left shunt. So the fourth assessment is assessment of pulmonary artery pressures based on the assessment of interventricular septum configuration. So this can be seen either in the apical view or in the short axis view. So this is the right ventricle and this is the left ventricle. So normally left ventricle is going to be round shaped, O-shaped. So this means the pressures are normal. Whereas in the presence of high RV pressures or moderate pulmonary hypertension, the septum is going to become flat. And in the presence of severe pulmonary hypertension, the septum is going into the left ventricle, leading to a crescent-shaped LV. So we can estimate the right ventricular pressures based on the LV configuration also. So O-shaped left ventricle, if there is O-shaped left ventricle, it means the right ventricular pressures are less than 50% of the left ventricular pressures. If there is D-shaped LV, it means the right ventricular pressures are 50 to 100% of left ventricular pressures. And in the presence of crescent-shaped LV, the right ventricular pressures are more than or equal to 100% of the left ventricular pressures. The fifth part is qualitative assessment of right ventricular, right atrial, and pulmonary diameters. So because of increased pulmonary vascular resistance, there is increased pulmonary artery diameter, and there is impaired right ventricular systolic and diastolic performance, leading to dilatation of RA, RV, and inferior vena cava, that is right-sided heart failure. So if you see the first video, the right ventricle and the right atrium are dilated. They are contracting, but when you compare it with the left ventricle, the contraction is much lesser. So the same thing we are seeing in parasternal long axis view. This is the left ventricle, this is the right ventricle. Right ventricle is apparently looking dilated, it is bulging into the left ventricle, and the left ventricular cavity is also decreased. So coming to the diameters of pulmonary artery. So this is in ductal view. This is the main pulmonary artery. This is RPA, this is LPA, and this is the duct. So you can see the pulmonary artery is very grossly dilated. Both the RPA and LPA are also grossly dilated. There is a very large PDA. And if we place the color Doppler also, we are able to appreciate the large diameters. And we are able to appreciate bidirectional shunt across the PDA. So if you see this echo, the RA and the RV are appearing dilated. The contractility looks okay. But what is very obvious here is the left ventricle is not at all contracting. When you compare it with the right side, the left ventricle is hardly contracting. So this is a case of left ventricular dysfunction. So while all these are good, but they are only subjective findings. So what I may feel as dilated or poor contractility may be looking normal to other person. So there are some other objective findings to assess the right ventricular function. One of them is TAPSE, that is tricuspid annular pain systolic exertion. TAPSE is a measure of right ventricular longitudinal function. So in 4-chamber view, we are going to place the cursor aligned along the direction of lateral annulus, and a mode is placed. So TAPSE basically provides useful information about longitudinal fiber shortening, and it correlates well with RV global systolic function. But it is also very dependent on angle and load. And diminished TAPSE of less than 4 mm is predictive for the need for ECMO and death in infants with PPHN. So we are going to place a cursor along the lateral annulus, and we are going to measure the diameter of the tricuspid annulus has traveled both in systole as well as diastole, and we're going to see it in M mode. So the distance is calculated and it is expressed in millimeters, and if it is less than 4 mm, it is predictive of need for ECMO or severe PPHN. So the next important thing to assess pulmonary pressures is pulmonary artery acceleration time, PAAT. So normally the peak of pulmonary artery acceleration occurs 30 to 40% of the cycle. After the 30 to 40% of cycle, this is normal acceleration. But in the presence of pulmonary hypertension, the peak is reached very early. That is short acceleration time. So this is usually measured in parasternal long axis view. We are going to see in low parasternal long axis view, we are going to place a Doppler across the pulmonary artery. The pulsar Doppler is placed, and here we can see the pulmonary acceleration is reached almost normally. But when you see it in a case of PPHN, the peak has arrived much earlier. So along with PAAT, we can see the ratio of PAAT by right ventricular ejection time. So this also indicates PAH. So the uses of PAAT and PAAT by RVT, they're all feasible, reproducible, and non-invasive, and they correlate well with the catheterization-derived pulmonary artery pressures. So if the PAAT is less than 90 milliseconds, it means there is pulmonary vascular disease, and if it is less than 40 milliseconds, it means there is very severe PPHN. The normal PAAT by RVT is 0.31 or greater, whereas PAAT by RVT of less than 0.23 is indicative of increased pulmonary artery pressures. So having seen all the changes of PPHN on the echo, how do we grade the severity of PPHN? So if a baby is on 100% FiO2 and the PaO2s are still less than 50 mm of Hg, which means there is very severe form of PPHN. And the other objective things are oxygenation index, where we see map into FiO2 by 100 into PaO2. So if it is up to 15, it is mild form of PH, 15 to 25 is moderate, 25 to 40 is severe, and in very severe, we see OI of more than 40. Coming to echocardiographic parameters which indicate the severity of PPHN, a crescent-shaped LV, continuous right to left shunt, PAT of less than 40 seconds, and taxi of less than 4 mm are indicative of very severe PPHN. We can also measure the arterial alveolar oxygenation gradient. If it is more than 600 for 6 to 8 hours, it indicates very severe PPHN. So coming to the management, first let's start with the delivery room management. In the delivery room, we need to avoid hyperoxia because hypoxia increases pulmonary vascular resistance, normoxia improves pulmonary vasodilatation, but any additional hyperoxia is not going to further increase pulmonary vasodilatation. But because of the free radical injury, there is toxicity, especially when it is combined with INO. So we need to maintain the preductal saturations at minute specific gradients as mentioned in the NRP. So we usually measure preductal and postductal saturations in any baby with PPHN. So preductal saturations are very important because they are going to indicate the cerebral and coronary circulation. We need to target a preductal saturations of 90 to 97%. And postductal, we can tolerate anything even above 80 to 85%, especially if the pH is more than 7.25, the baby is having normal urine output and the lactate levels are also normal, less than 3. But the only exceptions to this rule is a baby with asphyxia who will need a higher SpO2 targets, and baby who's on lower FiO2 but echo is suggestive of very severe PPHN, and baby who's on cooling device for asphyxia but echo is suggestive of severe PPHN, and in the presence of drop in urine output with rising lactate levels. So the principles of management of PPHN are mainly treating stressors, optimal lung recruitment, ruling out duct-dependent lesions, maintaining adequate BP and avoiding supraphysiological systemic pressures, and use of vasodilators like INO, inotropes, and vasodilators. So inhaled nitric oxide is the main management therapy in PPHN, but we are going to discuss that in the next class by Dr. Arvinda. So the first component is avoiding stressors. We need to maintain a normal temperature of 36.5 to 37.5 if there is no asphyxia. We need to maintain an optimal fluid balance, a PC of more than 45, normal glucose levels of 50 to 120, optimal calories, normal calcium levels. We also need to avoid stressors and handling of baby. Clustering of care should be done. We need to apply eye patches, ear plugs, urine catheterization to be done to monitor urine output. And we can use fentanyl infusions for sedation, and fentanyl also helps in reducing the PVR. Paralysis should not be used. So the second component is recruitment of lung fills. Gentle ventilation needs to be done. There needs to be tolerable hypoxemia with PaO2 levels of 50 to 80 and preductal saturations of 90 to 97%. We need to have a PIP just enough to cause chest rise, and the respiratory rates need to match the patient's respiratory rate. Permissive hypercapnia can be tolerated. Earlier we used to use hyperventilation with which resulted in hypocapnia and brain injuries. So nowadays that is obsolete, and we need to target PaCO2 levels of 50 to 60. As long as the pH is more than 7.25, lactate is less than 3, urine output is more than 1 ml/kg per hour, then we can tolerate postductal saturations of 80 and above. So these are the three X-rays. The first one is secondary PPHN due to parenchymal lung disease or RDS, there is complete whiteout. So in such cases, we need to give optimal PEEP. We need to recruit the lungs with the help of ventilation or CPAP with optimal PEEPs. We need to increase MAP. We need to give surfactant. And if there is pneumonia, we can treat it with antibiotics. The second one is idiopathic PPHN, where the lungs are normal. So here we can just use lung protective strategies. We need not give very high pressures or very high PEEP. And the third one is secondary PPHN due to lung hyperplasia. Here we need to be very cautious with the lung protective strategies, avoid overexpansion. We need to use minimal PEEPs of about 3 or 4. And we can tolerate CO2 levels of 50 to 60, saturation levels of above 80%. And a little lower PaO2 targets can also be tolerated, like 45 to 60 mm of Hg. So in secondary PPHN, don't be scared of PEEP, do optimal lung recruitment. In primary PPHN, avoid excessive PEEP and pressures. And in lung hyperplasia, avoid lung injury, say no to wall trauma, give gentle ventilation, and just adequate PEEP to maintain saturations above 80%. So lung recruitment is very important at very low lung, at atelectasis with the very low lung recruitment, the PVR is going to increase. Simultaneously, if there is very hyperinflation also, PVR is going to increase. So we need to maintain the chest expansion at 8 to 9 rib expansion. Coming to acidosis and PPHN, acidosis is usually seen in a case of asphyxia or sepsis. Acidosis also aggravates pulmonary vasoconstriction. And in the presence of acidosis, if there is hypoxia, it will further aggravate PVR. So always avoid alkalis, especially in the presence of acidosis, because it increases the risk of ECMO. Coming to therapeutic hypothermia and PPHN. So hypothermia aggravates PVR, and hypothermia also shifts the oxygen dissociation curve to the left. So to maintain the same PO2 levels of 50 to 75%, because of shift to the dissociation curve to the left, the oxygen delivery to the tissues is going to be reduced, and hence in babies with cooling, we need to target a little higher SpO2 levels. So coming to surfactant therapy. In the absence of surfactant, when the lungs are collapsed, usually even INO is not going to act, because INO is only going to act in the lungs which are distended. And also the alveolar vessels are constricted due to lack of INO and hypoxia. And when surfactant is given by Laplace effect, the alveoli are going to expand well, the surface tension increases, and even the INO also penetrates well and causes optimal lung recruitment and decrease of PPHN. So surfactant is very useful and reduces the risk of ECMO and death, but only in secondary PPHN caused because of parenchymal disease. So in RDS, we typically use surfactant if there is a FiO2 of more than 30%. And in the presence of pneumonia, sepsis, MSL, pulmonary hemorrhage, we usually give surfactant if the FiO2 requirement is more than 40%. But in primary PPHN without lung injury, surfactant is not necessary, and inhaled nitric oxide is sufficient. So surfactant is usually given at OAI of more than 5 and FiO2 requirement of 30 to 40%. But we need to exercise caution in CDH or idiopathic PPHN. The second strategy after mechanical ventilation is HFO. HFO is used whenever we require very high PIPs of 25 to 28 or volumes of more than 6 ml per kg to maintain PaCO2 levels of less than 60 mm of mercury. So HFO is going to be useful in parenchymal lung disease with PPHN, but in primary PPHN, lung recruitment with HFO is not going to be very useful. So having discussed the lung part, let's discuss the heart part. So in any case of PPHN, always maintain BP in physiological range. Just because the pulmonary pressures are in supraphysiological ranges, we shouldn't target supraphysiological systemic BPs also, because that is going to further increase the load on the heart and may lead to hypertensive heart failure. And always avoid pulmonary vasoconstrictors like dopamine as first line. So whatever inotropes we are increasing, as it is going to increase the SVR, even some of the drugs are going to increase the pulmonary vascular resistance also. So we always need to use the drugs with low PVR by SVR ratio. So let's discuss one by one. So sildenafil basically causes decrease in PVR and decrease in SVR. That is, it causes both pulmonary vasodilatation and also it also causes hypotension. So it is very useful in a case of PPHN with right to left shunt, and it acts additive to inhaled nitric oxide. So milrinone is also similar to sildenafil in decreasing PVR and SVR, but it also has inotropic effect. So it is very useful in the case of cardiac dysfunction, and it also has lucitropic effect and does not cause much of tachycardia. Epinephrine is having inotropic effect at lower levels. At low levels, it is not going to increase PVR, but at high doses, that is more than 0.12 microgram per kg per minute, it increases PVR and hence should be used with caution in PPHN. So norepinephrine also causes increased SVR and PVR, but the increase in SVR is more when compared to PVR, and usually this is not seen very evidently clinically. It also has mild inotropic effect. So norepinephrine is very useful in the presence of septic shock associated with PPHN. So coming to dobutamine, it has a good inotropic effect. So it is useful in a baby with normotension in mild or moderate cardiac dysfunction. And vasopressin is very, very useful drug in PPHN because it increases PVR and it also causes pulmonary vasodilatation. Vasopressin along with milrinone is going to help in cases of severe PPHN not responding to INO. So coming to the inotropes, after optimal lung recruitment, if we need to do echo, if there is normal blood pressures with normal cardiac function, then we can just leave it. We need not start any inotropes. We just need to keep monitoring the blood pressures and do periodic echoes. If there is normal blood pressure with cardiac dysfunction, IV milrinone is the preferred choice of drug. In the presence of low blood pressures with good cardiac function, we can use norepinephrine or vasopressin. And in cases with low BP with cardiac dysfunction, these are the cases which deteriorate fast and need ECMO. In such cases, we can use epinephrine, vasopressin, dobutamine. We can give a fluid bolus carefully. And if the pressures are normalized after the using of epinephrine and vasopressin, we can use milrinone. Hydrocort also can be used after taking a baseline cortisol level, and we need to make sure that there is no infection, bacterial, viral, or fungal infection. So in a case with normal BP and normal heart, just monitor. In a case with low BP and normal heart, we can use norepinephrine and vasopressin. Normal BP with cardiac dysfunction, milrinone is the first choice of drug. We can also use dobutamine or epinephrine. And in a case with low BP and cardiac dysfunction, we prefer to use epinephrine, and there is high risk for ECMO in such cases. So coming to sildenafil, sildenafil is a phosphodiesterase 5 inhibitor. It is a very potent selective pulmonary vasodilator, but it also causes hypotension. It acts synergistically along with inhaled nitric oxide and helps in weaning the inhaled nitric oxide dose. Sildenafil is metabolized by the liver, and hence in severe hepatic dysfunction, it might impair its metabolism. We usually prefer IV route, giving a loading dose of 0.4 mg per kg over 3 hours, followed by 1.6 mg per kg per day. Oral dosage is given at the rate of 1 to 2 mg per kg per dose 6 hourly. Oral route is usually preferred in chronic PPHN such as BPD. So it is very useful in cases of renal dysfunction with normal liver. The major side effects are pulmonary hemorrhage and hypotension. So always use only if the blood pressures are normal. So PPHN with RV failure is one separate entity. So because of increased pulmonary pressures, we have discussed that there is increased RV afterload. There is systolic and diastolic dysfunction, which further causes right ventricular dilatation and failure. If the PDA is also closed in such cases, then the right heart is going to go into failure. So in such cases, the drug which is very helpful is PGE1. So in any case of RV dysfunction, first we need to optimize RV preload. We may give bolus, but very cautiously after seeing the IVC. We need to vein map, we can consider vasopressors, we need to drain if there are any effusions, and we need to augment the systolic function by using dobutamine or milrinone if the baby is normotensive, and epinephrine in the presence of hypotension or signs of septic shock. And we also need to decrease the RV afterload by using inhaled nitric oxide, non-selective vasodilators like milrinone in the presence of normal BP, and low-dose PGE1 is very helpful in such cases in the presence of a closed ductus arteriosus or restrictive. So in severe RV dysfunction with RV failure and closing ductus, PGE1 is a life-saving entity. So it acts as a pop-up valve and decreases the RV afterload. It also causes pulmonary vasodilatation, so that is also a boon in case of PPHN. The side effects are apnea, fever, and rash. So PGE1 should be only administered in a level 3 NICU when there is someone available to do intubation if needed. The contraindications of PGE1 are hypotension and shock. So dose used is usually 0.01 to 0.05 microgram per kg per minute. Bosentan is another useful drug which is given orally in a case of PPHN. It is given at a dose of 1 mg per kg per dose 12 hourly for 72 hours and then tapered over 2 days. The side effect being Bosentan is a hepatotoxic drug. It may lead to pulmonary hemorrhage or flushing. So LV dysfunction is one other separate entity of in a PPHN where it should be managed differently. LV dysfunction is usually seen in CDH, sepsis, asphyxia, or in a baby who is undergoing cooling. So in such cases, if you are going to give INO, it is going to be counterproductive because there is going to be increase in pulmonary edema. So in these cases, milrinone is a very useful drug. So we have discussed this previously. In a case of LV dysfunction, we usually see paradoxical right to left flow across the PDA, but left to right flow across the PFO. So in these cases, since the systemic circulation is dependent on the RV and also we need to increase the left ventricular systolic function, we can use either milrinone or in case if the duct is closing, we can use PGE1. So milrinone is going to be very useful in INO-resistant PPHN. It improves oxygenation. It is an adjunct to INO. It is given at a loading of 50 microgram per kg over 1 hour, but usually we don't use this. And the maintenance dose of 0.33 to 0.99 microgram per kg per minute is given. So always avoid milrinone in AKI because it is having poor clearance. It is cleared through the kidneys. So because of that, there can be milrinone is going to accumulate in the body leading to hypotension. And always avoid in asphyxia with renal dysfunction. So in asphyxia with PPHN, it is better if you avoid milrinone. And never use milrinone in the presence of hypotension, shock, or renal dysfunction. So let's discuss once again the acute therapy of PPHN. So the first main thing is minimal stimulation use, eye cover, earmuffs, etc. We need to use sedation and analgesia, avoid paralysis. So lung recruitment should be done in parenchymal lung disease with surfactant, gentle ventilation, HFO if there is increase in PIP of more than 28 or volumes of more than 6 ml per kg to maintain PaCO2 of less than 60. So we can target PaO2 levels of 90 to 97% preductally and more than 85% postductally. And blood pressure should be carefully monitored. If there is hypotension, we can give careful bolus followed by pressor therapy. So coming to the prognosis in a case of PPHN, death is seen in almost 10 to 15% of cases of PPHN. And cerebral palsy is also seen in 5% of cases of PPHN, and neurological handicap is seen in 25% of cases of PPHN. Deafness in 23%, and learning disabilities are also seen in some babies. So to sum up, failure of fatal to neonatal cardiopulmonary transition at birth results in PPHN. So always suspect PPHN when there are labile saturations with hypoxemia disproportionate to the parenchymal lung disease. In a case of idiopathic PPHN, always rule out the genetic variants and always monitor preductal and postductal saturations in a baby with hypoxemia. Echo is gold standard in diagnosing, managing, and weaning of therapies. Always rule out duct-dependent lesions before starting INO. And supportive care is very important as vasodilator therapy in a case of PPHN. So this completes my presentation. So thank you, everybody. Are there any doubts? Any doubts? So we'll close the session then. Thank you everyone for listening.